Good evening. Mercifully, I'm not going to be too long. Very, very brief. I know the hour is late, and there are more important topics to be covered by other speakers, and I simply want to make a few remarks about the conceptual basis for what's going to be recommended as a new paradigm for screening for cardiovascular. And the question that Mort posed was a rather provocative one. What have we learned from President Clinton's recent debacle with coronary artery disease? And I think if you ask 10 people, you probably will have 10 different answers. But what I really learned was that he wished, like the Democrats, he wished that the best way to prevent coronary heart disease is a no-carb diet. No Cheney, no Ashcroft, no Rumsfeld, no Bush, and certainly no rice. But regrettably, I think
you're 200,000 volts far from
these individuals are here to stay with us for some time, so we have to figure out better ways of preventing.
It's John Rumberger's fault.
That's right. Anyway, I just want to get back to, I think most of my stuff has already been covered by Mort, but I want to just give you the conceptual framework that is underneath this attempt to change the paradigm for screening. We need to do a better job of identifying individuals before they have a first coronary event. And the imperative is clear, because 40 to 50% of first events will be a major myocardial infarction or sudden cardiac death. And that's why primary prevention is absolutely important in this particular field. And I will take you through this complicated slide, but the message is really very simple. On the very top is a broad list, a category of risk factors. And at the bottom is what we are trying to prevent. And you think of this as a funnel with a very broad base at the top. We have a lot of risk factors that lead to eventually inflammatory gene activation. And I, like many people, believe that inflammation is at the center of atherogenesis and its complications. And then this eventually leads to atherosclerosis, and that episodically leads to acute vaso-occlusive events. And clearly, we start with a lot of people who have these risk factors. We end up with a few people, significant, but substantially less than those that have the risk factors. We end up with a much smaller category of individuals, a number of individuals who land up here. And yet, most of what we do is applied to this group here at the very top in order to prevent a substantially smaller proportion of events at the bottom. That's what we do with the conventional paradigm. We completely ignore that to go from here to here is regulated by a number of factors which determine the susceptibility to risk factors inducing atherosclerosis. Part of that is genetic. In fact, I think a strong component of that is genes. Winston Churchill smoked and ate everything he liked, and he lived to be 90. Jim Fixx didn't even smoke and followed a heart-healthy diet and died in his 40s or 50s. And how so? I think this is the variation here to susceptibility that we have more or less not gotten a very good handle on, and hopefully with genomics and proteomics we will have a better handle. And this is now simplified into this funnel paradigm that I call the funnel paradigm. A lot of people here with risk factors. Few of them will actually develop the disease, and even fewer will actually develop the most drastic vaso-occlusive events. And therefore, our approach, which starts here for screening and implementation of risk factor modification, really makes it virtually impossible, because you're dealing with a huge part of people, and by conservative estimates, as Maud indicated, close to 55 million people. And we're trying to apply everything to all of those 55 million in order to prevent about 10 million events, or whatever the the ratio there is. And it is not likely to be a very cost-effective strategy. What we want to be is at least somewhere closer to here, where your starting point is here. So you have eliminated a lot of the people who have risk factors but don't have the disease. And if you start here, you already decrease the ratio. You're already likely to be limiting your applications and interventions and further evaluation to a much smaller pool than what you start out here. And I think that's really the central paradigm that we are trying to consider. Now, those of you who believe, either Salim Yusuf or Phil Greenland, that 80 to 90% of all vaso-occlusive events are predicted by risk factors, and therefore, if we eliminate risk factors in everyone, we will eliminate 90% of heart attacks. I think that's kind of... Well, there's a real interesting paradox there that is illustrated in this slide. This is actually looking at Greenland's data. I think Mort showed it. If you look at those who died of coronary heart disease or died or had a non-fatal MI, the prevalence of more than one risk factor is close to 80 to 90%. No dispute there. One or more. If you're 55, you already have one risk factor as a male or as a female, and 45 as a male. But you look at these people who didn't die and didn't have a myocardial infarction, the prevalence of one or more risk factors is damn close. And therein lies the problem of basing everything on risk factor assessment. We're going to land up not only treating all these people, but a large number of those who have the risk factors but don't have an event. And I think this is actual data. This is no longer a hypothesis. This is real data. So when I gave a talk a couple of years ago on risk identification, and that's when it kind of dawned on me that we're really approaching this disease from the wrong perspective. We need to really not look at just risk factors, but look at the disease itself as the starting point. If the disease can be identified effectively, safely, and simply. And I think we are entering that era where the disease can be identified quite effectively, reasonably safely, and probably reasonably cost effectively, although that remains to be still evaluated. So we're looking at, therefore, three components of this puzzle. That is the arterial structure, which means atherosclerosis, or something that predisposes to atherosclerosis, such as thickened carotid intima media. Although not truly atherosclerosis, we can call it pre-atherosclerosis, okay, depending on how strong you want to be on semantics. Abnormal structure may either lead to abnormal function, or abnormal function may even antedate the appearance of abnormal structure. And what do we mean by abnormal function? You can take a broad view of it. Say abnormal function means there is a flow limiting lesion, so you have abnormal flow dynamics, or you have abnormal endothelial dependent vasodilator response, or you have reduced compliance or increased stiffness of the vessel. It's a functional consequence. So taking a broad view of that, we're looking at function. And then some nebulous parameter, which for want of a better term, I've called disease activity. And how do we define disease activity? It's propensity to developing a thrombus, I think would be the simplest way to define it. What is the propensity to thrombus? Either via plaque rupture or whatever other mechanisms are involved in thrombosis. Is there any way to assess that? We think of biomarkers, CRP, LPPLA2, as markers of inflammation, knowing that inflammation and atherogenesis are linked. Therefore, could those be the parameters that could be useful? Or could genomic data help us in identifying SNPs or polymorphisms in critical genes that actually give us additional insight into who is at risk beyond what we can do by simply looking at the plaque itself? And of course, identifying the type of plaque is another, like identifying inflammatory activity in the plaque itself may also be a manifestation of disease activity. So conceptually, if we can look at atherosclerotic vascular disease within the framework of structure, function, and some descriptor or activity or tempo of the disease, then that's probably going to be the more effective way to identify patients who are really at risk of developing. Ultimately, we don't care about stable angina. What we're really concerned about is acute vaso-occlusive events, sudden death or myocardial infarction. Those are the kinds of events we want to avoid. So again, using this paradigm, we can actually really narrow our list down to this stage where we are identifying disease. And one may be able to further characterize from this stage based on function and based on disease activity and further narrow the list down and really get more effective in identifying those individuals who are truly at risk without a huge number of inclusions of individuals who are not really at risk for acute vaso-occlusive events. So without really mentioning specific techniques in any detail, as a clinician, I have no vested interest in imaging or biomarkers. I take care of patients. I want to see what is best for my patients, what will help me best. And therefore, coming from that perspective, what do I use? Well, for this, I frequently use EBCT as a surrogate for atherosclerosis, although carotid IMT may also do the job. And as Valentin has shown, at some point, MRI may become more generally available and less costly and perhaps more versatile, and that would be another technique to identify atherosclerotic disease burden. How do we do this? Well, stress testing is a time-honored test for ischemia to assess abnormal flow reserve. Endothelial function has not quite made it into the mainstream because of technical limitations, and measuring arterial stiffness or compliance that Dr. Jay Cohn has been studying and is something that is coming into clinical practice because the instrumentation is relatively simple and the measurements are reproducible and relatively simple, although the amount of data we have for EBCT and other things is not yet available for those kinds of measurements, but I think progress in that arena may help us further refine our risk assessment. And furthermore, down here I've talked about the biomarkers, single nucleotide polymorphisms with the genomic revolution. I think there's likely to be information in here, although we're not quite there yet. And proteomics looks very promising to identify protein patterns in circulating blood that might reflect in some way the burden of disease or the tempo of the disease. And so I think this is kind of the approach that is embodied in this new emerging paradigm that you're going to hear more detail about in a moment. Thank you very much.